Welcome to This Week in Rheumatology. This week we are covering 8 notable papers spanning advances in spondyloarthritis diagnosis and tracking, the genetic and therapeutic landscapes of giant cell arteritis, and emerging tools to predict complications in systemic lupus erythematosus, autoinflammatory diseases, and pregnancy. Let us dive in. We begin with spondyloarthritis, where diagnostic precision and standardized disease assessment remain major clinical hurdles. In a prospective multicentre project, researchers evaluated the impact of centralizing clinical and imaging evaluations for patients suspected of having axial spondyloarthritis. By setting up a central telemedicine platform, the investigators collected clinical, laboratory, and imaging data on nearly 1,000 patients who had been evaluated by local rheumatologists and orthopedists. The findings expose a stark discrepancy in real-world diagnostics. While local clinicians diagnosed roughly 27% of these patients with axial spondyloarthritis, a central expert review confirmed the diagnosis in only about 54% of those cases. For more than a third of the patients locally diagnosed with the condition, the central experts concluded that alternative diagnoses, most commonly degenerative or mechanical back disorders, were far more likely. This diagnostic gap was primarily driven by different interpretations of imaging findings, suggesting that remote expert consultation could significantly reduce the risk of misdiagnosis. Once a correct diagnosis of spondyloarthritis is established, monitoring peripheral arthritis presents its own set of challenges. To address this, the Assessment of Spondyloarthritis International Society, or ASAIS, conducted a project following the OMERACT framework to identify the most appropriate instrument for assessing peripheral joint disease activity in both axial and peripheral spondyloarthritis. Also, this study evaluated several candidate instruments through systematic literature reviews and individual patient data from 13 randomized controlled trials. The research team found that composite disease activity instruments consistently outperformed single-item measures such as joint counts alone. Among the options, the Disease Activity Index for psoriatic arthritis based on 44 joints, known as DAPSA-44, demonstrated the best construct validity, responsiveness, and clinical trial discrimination across both disease types. Consequently, the ASAS consensus voting resulted in overwhelming agreement, with 92% for axial and 97% for peripheral spondyloarthritis, officially endorsing DAPSA-44 as the recommended instrument for assessing peripheral arthritis in clinical research. For practicing clinicians, these studies emphasize the critical need for expert imaging review to avoid misdiagnosis and highlight the value of adopting composite scores like DAPSA-44 to accurately capture peripheral disease activity. Moving on to giant cell arteritis, we see major steps forward in understanding both the genetic heterogeneity of the disease and the long-term consequences of its treatment. A genome-wide association study published in Annals of the Rheumatic Diseases analyzed genetic data from nearly 3,500 patients with giant cell arteritis and more than 15,000 controls to uncover genetic risk factors associated with specific clinical manifestations. The researchers identified 7 human leukocyte antigen variants and 7 non-human leukocyte antigen associations linked to distinct clinical features. For example, variants in the interleukin-17A and interleukin-22 receptor alpha-1 genes, which are key players in the T helper 17 pathway, were linked to limb and jaw claudication respectively. Additionally, variants in the ATP2A2 gene, which promotes aortic aneurysms, were associated with the extracranial form of the disease. Using latent class analysis, the authors classified giant cell arteritis into 4 genetic subgroups: cranial predominant, mixed, extracranial, and an ischemic or occlusive pattern. This ischemic subgroup represents patients at particularly high risk for severe ocular and ischemic complications, offering a potential path toward genetic profiling to guide early diagnosis and personalized management. This genetic stratification is especially critical given the high burden of traditional therapies. In a nationwide real-world study, researchers utilized the French National Health Insurance Database to analyze treatment patterns and glucocorticoid-associated burdens in over 18,000 patients diagnosed with giant cell arteritis between 2010 and 2022. Although the use of steroid-sparing agents like tocilizumab rose significantly, reaching over 25% of patients by 2022, the cumulative exposure to glucocorticoids remained remarkably high. Patients diagnosed in 2022 still received a mean cumulative dose of 7.6 grams over 2 years. The clinical consequences of this exposure were stark. every single gram of cumulative glucocorticoids was associated with a 2.4% increase in mortality. Even more sobering, maintaining patients on very low doses of 5 mg per day or less was still associated with a 13% increase in serious infections and a 4% increase in major adverse cardiovascular events. These findings serve as a powerful reminder that there is no truly safe dose of glucocorticoids, and clinicians should aggressively pursue steroid-sparing strategies as early as possible. Next, we turn to systemic inflammatory and autoinflammatory conditions, where better risk prediction tools are desperately needed. In systemic lupus erythematosus, predicting which patient flares will lead to permanent organ damage has long been a challenge. A study in Annals of the Rheumatic Diseases sought to move beyond the traditional mild, moderate, or severe classification of flares by developing a data-driven, weighted flare score. Analyzing a cohort of 354 patients followed for a median of 66 months, and validating the findings in an independent cohort of 110 patients, researchers found that both mild to moderate and severe flares increased the risk of organ damage at 12 months. However, by weighting specific criteria, they created a highly predictive score. Major organ involvement requiring high-dose glucocorticoids received the highest weight of 6, while isolated glucocorticoid escalation received weights between 1.5 and 3, and minor organ involvement received a weight of 1. A flare score threshold of 3.5 or greater successfully identified a subset of high-risk flares, representing about 40% of all episodes that more than double the risk of subsequent organ damage. Interestingly, while achieving a lupus low disease activity state or remission correlated with fewer overall flares, only sustained remission, defined as being in remission for more than half of the follow-up period, successfully reduced these high-risk damage-promoting flares. This score provides clinicians with a practical tool to identify patients who require immediate, aggressive intervention to prevent long-term damage. In another effort to improve diagnostic accuracy, researchers publishing in RMD Open developed a machine learning model to identify adult-onset Still's disease among patients presenting with fever of unknown origin. Because this autoinflammatory disorder lacks a gold standard diagnostic test, diagnosis is often delayed. Utilizing clinical data from over 800 patients in China, the researchers selected 6 key features to build their predictive model: age, neutrophil percentage, white blood cell count, infection indicators, ferritin levels, and an adult onset Still's disease clinical presentation score. A logistic regression model, utilizing these features, achieved outstanding accuracy with an area under the curve of 0.96 in the training set and 0.90 in an independent external validation cohort. This model, presented as a clinical nomogram, offers a highly accessible way for clinicians to evaluate patients with unexplained fevers and secure an earlier diagnosis. When systemic inflammatory diseases spiral out of control, they can trigger macrophage activation syndrome, a life-threatening complication. A retrospective study. The etiologies were highly diverse, led by multisystem inflammatory syndrome in children at roughly 37%, followed by systemic juvenile idiopathic arthritis at nearly 27%, and infection-triggered cases at 23%. The overall mortality was high at 17.5%, and 60% of patients required intensive care. Children with non-systemic juvenile idiopathic arthritis etiologies had significantly higher rates of intensive care admission and mortality compared to those with systemic juvenile idiopathic arthritis, though the latter group experienced far more disease recurrences. Genetic testing in a subgroup revealed that nearly 22% carried hemophagocytic lymphohistiocytosis-related gene variants. Carrying these variants was independently associated with younger age of onset, higher ferritin levels, acute organ dysfunction, and recurrent disease, suggesting that genetic screening could help identify children at risk for a more severe or relapsing clinical course. Finally, we address reproductive health in patients with rheumatoid arthritis. While modern management has improved outcomes, a prospective matched cohort study comparing 100 pregnancies in 90 women with rheumatoid arthritis to over 300 matched controls from the general French population, the researchers found that women with rheumatoid arthritis had a roughly double risk of both preterm birth and delivering a baby that was small for gestational age. When looking at risk factors within the rheumatoid arthritis group, delivering a small for gestational age infant was strongly associated with being nulliparous, which carried a more than 4-fold increased risk. Crucially, preterm birth was heavily driven by maternal age and exposure to systemic glucocorticoids at doses of 10 mg per day or higher during pregnancy, which increased the risk of preterm delivery nearly fivefold. While some of this risk may reflect underlying disease activity, the strong association with moderate to high-dose steroids underscores the clinical mandate to optimize non-steroidal pregnancy-compatible maintenance therapies before and during pregnancy to minimize steroid dependency. If you only have time for one paper this week, make it the prospective multicentre study on centralized clinical and imaging evaluation in axial spondyloarthritis. This paper is our editor's pick because it exposes a major real-world clinical vulnerability: the fact that over a third of patients diagnosed with axial spondyloarthritis by local clinicians actually had alternative non-inflammatory causes for their back pain upon expert review. It serves as an urgent call to action for the rheumatology community to implement remote telemedicine expert reviews, particularly for imaging interpretation, to prevent the profound physical, psychological, and financial consequences of misdiagnosis. Here are the key takeaways from this week in rheumatology. First, diagnostic caution is required in suspected axial spondyloarthritis, as local evaluations frequently misinterpret degenerative or mechanical imaging findings as inflammatory. Utilizing centralized expert remote reviews can dramatically improve diagnostic accuracy. Second, when assessing peripheral arthritis in patients with spondyloarthritis, clinicians should transition from simple joint counts to composite disease activity measures, specifically adopting the DAPSA-44 instrument, which is now officially endorsed by the Assessment of Spondyloarthritis International Society. Third, there is no safe dose of glucocorticoids in giant cell arteritis, as even low-maintenance doses of 5 mg per day or less are tied to higher rates of infection and cardiovascular events, and every cumulative gram increases mortality risk. Fourth, in systemic lupus erythematosus, a weighted flare score utilizing a threshold of 3.5 or higher can identify the 40% of flares that carry the highest risk for long-term organ damage, and only sustained remission can prevent these high-risk episodes. Fifth, pregnancies in women with rheumatoid arthritis remain at elevated risk for preterm birth and small for gestational age infants, with glucocorticoid doses of 10 mg per day or higher during pregnancy, multiplying the risk of preterm birth nearly fivefold. That's your roundup for this week in rheumatology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.